I'd like to introduce Dr. Jay Bhattacharya. He is a professor of medicine at Stanford University and a research associate at the National Bureau of Economics Research. In addition to his medical doctorate, he also earned a PhD in economics, both from Stanford University. Dr. Bhattacharya's recent research focuses on the epidemiology of COVID-19, as well as an evaluation of the policy responses to the epidemic. He has published 135 articles in top peer-reviewed journals in medicine, economics, health policy, epidemiology, and public health. He's one of the 3 lead authors of the GB Declaration, now signed by close to 500,000 people worldwide. Thank you.
Welcome, everyone. I'm Professor Jay Bhattacharya, a professor of medicine at Stanford University. Today, I'm going to be talking to you about COVID mortality and mitigation effects. And I'll tell you about the Great Barrington Declaration, which is a proposal that I've been involved with to try to use the science that's been emerging on these mortality effects and lockdown effects that I'll talk about to get a better outcome both for COVID and non-COVID outcomes. Okay, so I'm going to start with a little bit of talking about how we measure and think about how deadly is COVID-19 infection. The key idea is that when you think about a COVID mortality rate, you want to measure the number of people who have had the COVID infection, and then in the numerator, you'll have the number of people who die from COVID. It seems simple enough, but the problem is that when you do this, normally in most things that you see in the newspaper and elsewhere, people focus on COVID cases, the number of people who are identified with COVID, the COVID virus in them, or have symptoms or some similar such definition. In any case, the key thing there is that the person has to be identified by the medical care system as having COVID in order to be included in the denominator. So the case fatality rate is the number of deaths among the cases. That's a case that's identified by the medical care system divided by the number of cases. Well, actually, if you plot the case fatality rate over time, what you see is that COVID seems like it was way more deadly in early March. And over time, as it's actually declined in deadliness. You can extend this graph further and you get the same thing. So whereas in early March, it was 10, 20, 30% of people that had COVID were dying of it within 2 weeks, or identified as cases were dying of it in 2 weeks. In August, actually going into September, that fraction is less than 1%, so 1 in 100. Now what's going on here? There's a couple of things. One is important, is that we actually have improved treatments for COVID. Things like dexamethasone, remdesivir that were not available or not known about in early March. So we're sort of managing patients better with ventilators than we once were. So that's a good thing. But that's not the whole story. In fact, it's probably not even most of the story. Most of the story has to do with the fact that in early March, we were not identifying a very large fraction of the cases. We were reserving tests appropriately for people who we suspected had COVID. Whereas the expansion in tests brought in many times more people who wouldn't have been identified in early March as having COVID, but they wouldn't show up in early March because they didn't have very severe COVID. So this theme, this idea that we have infections that we don't see in the cases is a really important one. So the definition we want is the infection fatality rate. Here it's the number of deaths among the infected divided by the number of infected people. That's the true mortality risk from COVID if you happen to get infected. The case fatality rate is on a very select set of people who happen to become very sick with COVID, with pneumonia or whatnot. On the other hand, if you're not identified as a case, you don't belong. You won't show up in the denominator in the case fatality rate. But the infection fatality rate, that shows you how risky it is to actually get COVID. And so it's the number of deaths among the infected divided by the number of infected. So the key thing here, and probably you can guess from the discussion thus far, the number of cases is much smaller than the number of infected. Standard PCR tests check for active infections. They can't detect past or resolved infections. And if there's a selection bias in who gets checked, which there certainly is, it tends to be people who suspect they might be infected, especially in the early days of the pandemic. Okay, so the infection fatality rate then is the more important number for policy. And the case fatality rate provides a misleading and hard to predict, hard to interpret picture of the true risk of COVID mortality if you want that. Now, in March and February, the numbers that came out of China and other places were very, very high for the case fatality rates. The initial estimates were on the order of, for instance, the World Health Organization said 3.4%. That is 3 out of every 100 person that gets COVID, that was a case for COVID, dies. There's a paper in JAMA reporting out of the Chinese CDC that it was 2.3%. I mean, still a very, very high number. 2 out of 100 patients who get COVID die. The problem is that those were case fatality numbers, not infection fatality numbers. They didn't have in the denominator the set of people who were infected with COVID, which actually it turns out is going to be many, many times higher. So how do you figure out how many people have had exposure to COVID, or infected with COVID, when you can't just look at the number of cases? Well, what you have to do is you have to measure antibodies. So this is one measure of antibodies for people, specific antibodies infected with SARS-CoV-2, the virus that causes COVID. These will be positive for many, many patients even after they've cleared the virus. If you just look for the virus itself, that's in a patient, then you're going to underestimate the set of people who've been infected because you will miss the people who have got COVID and cleared it out of their system. The antibodies still persist. Now they fade over time. I mean, the average is coming in is that it's on the order of several months on average. So to some extent, we're gonna underestimate the set of people with a study like this who have had COVID infection. And there's also some people who react to virus with T-cell mediated immune response with minimal antibody formation. So again, we'll tend to underestimate. So this is sort of a lower bound on the number of infected people of a seroprevalence study like this. Nevertheless, it's a much better picture of the number of people previously infected than the number of identified cases, right? So it's worth looking at because, as we'll see, the infection fatality rate is very, very much lower than the case fatality rate. So I worked on, in the early days, in April, a series of studies. One was the Santa Clara County seroprevalence study. There we found is that there were roughly, in early April, there were about 1,000 cases in Santa Clara County, and we found about 50 times more patients with evidence, 50 times more people with evidence of antibodies in the population of Santa Clara than cases. I mean, it's about 50,000 cases. There were 1,000 cases at the time, about 100 deaths at the time, about a 2.8% prevalence rate. Well, if you look at that, it turns out that the case fatality rate at the time in Santa Clara was 10%, but the infection fatality rate turns out to be about 0.2%. I've worked on a couple of other seroprevalence studies as well, but rather than focus on those, I want to tell you that since the Santa Clara study, there have been now almost 80, actually more than 80 seroprevalence studies conducted all around the world. And they find numbers that are actually quite similar to the 2.2% I just mentioned. That's really important. That means the risk from dying from COVID is on the order of 2 in 1,000, not 10 in 100. An enormous difference, not 1 in 10, it's 2 in 1,000. And here I'm just going to show you very quickly, hoping you don't need to pay too close attention, but I'll show you some summaries from all of the seroprevalence studies have been done from around the world. And some places they find higher inferred IFR, means the inferred infection fatality rate. Some places they find lower. It turns out that 0.2 number is pretty close to the middle. The places that have had higher and worse outcomes, for instance, New York, you have had sort of a higher fraction of patients who were older that got infected. And in fact, if you, but even in New York, you get a higher IFR among people under 70 as well. But generally speaking, you see a very, very sharp difference in the infection fatality rate for people who are older and people who are younger. Sharp infection fatality rate between people who are younger and who are older. And here I give you three studies that have broken out the infection fatality rate by age, just to give you a sense of it. So for instance, in all three studies, the Geneva seroprevalence study, the Spanish seroprevalence study, and Santa Clara seroprevalence study, you have very, very close to zero deaths or zero infection fatality rate among children, which is a fantastically good news about this disease. It does not seem to preferentially kill children. In fact, children seem to be spared from mortality from this disease. The infection fatality rate rises with age, and so that there's almost a 1,000-fold difference between the infection fatality rate for the youngest and the infection fatality rate for the oldest populations. In Santa Clara, if you were 70 and over, the infection fatality rate was 2.2%. If you were in Spain and you were 70, 79, it was 3.4%. 80 and up, 7.2%. A really high infection fatality rate, 7 in 10, or 7 in 100 death rate. For Geneva, you can see no deaths among children, but 5.6 among 65 and up. So to summarize, and there was a study in Iceland which found 0.3, roughly what we found in Santa Clara just recently, published in the New England Journal of Medicine. So to summarize, the disease is much more widespread than the official case numbers would suggest. There are many, many times more people get the disease than you would expect from the case numbers. It's still a deadly disease, especially if you're older. And there's a wide range of clinical presentations, ranging from basically no symptoms at all, which is actually a very substantial fraction of the people who get COVID-19, to the SARS-CoV-2 virus, to people who have the deadly viral pneumonia that we all are familiar with. And the deadly viral pneumonia, that's actually a very small fraction of the cases. So on net, the death rate from COVID, the infection fatality rate from COVID seems to be on the order of 2 in 1,000. If you get infection from COVID, your death rate is roughly 2 in 1,000. If you're young, it's lower than that. It's on the order of like maybe 1 in 10,000. Whereas if you're older, say over 60, it might be as high as 2, 3, 4 in 100. Okay, let me briefly talk about, actually, you know what, I'm gonna skip over this and jump to some discussion about the anticipated harms and realized harms from the lockdowns. Now, of course, we've used in COVID, we've used a extraordinary measure, never before tried really in modern history, of shutting down our economy and shutting down our social life as a response to the COVID. To do that, we've asked people to stay at home, we've shut down businesses, we've closed down schools, we've done an enormous number of things. And as you might imagine, those things don't come with zero costs. The cost I want to focus on here are the costs to human health that have come as a result of these extraordinary non-pharmaceutical interventions. Let me just start with just one number from a report by the World Food Program in the United Nations from early April, or from late April. The finding there was that that they are anticipating this year 130 million additional people at risk of starvation as a consequence of the COVID-19 lockdowns and the economic collapse that they have caused. The last 20 some years, the world has lifted 1 billion people out of poverty. The world economy has lifted 1 billion people out of poverty. The COVID shutdowns, the lockdowns have in effect reversed a distressingly large fraction of that, such that 130 million lives are at stake from starvation. In the United States in 2008, there was the Great Recession, and we saw as a consequence of that, a rise in depression and a rise in opioid use, the famous deaths of despair. Well, we're seeing the same thing in the face of the lockdowns in the United States, increase in reports of opioid-related overdose and others during the pandemic. These are lockdown effects. These are because of the psychological harm from being locked down. Missed vaccinations. So, for instance, the Pennsylvania State Department of Health temporarily suspended requirements for child immunizations because parents were too concerned about COVID to bring their children in to get immunized. Worldwide, the World Health Organization estimates that at least 80 million children will be at risk of diseases like diphtheria, measles, and polio, because the COVID-19 disrupts the routine vaccination efforts by Gavi, WHO, and UNICEF and other agencies. They're diseases that we have made a substantial progress in addressing, deadly ones like the measles and polio, that are likely to see some outbreaks as a consequence of the COVID-19 lockdowns. Missed health services, so the number of people identified with newly identified cancer have dropped very, very sharply because people were more afraid of COVID than they were of their cancer. Managing patients with diabetes also dropped very, very substantially during the lockdowns, and continue to stay below our baseline levels. And finally, mental health harms. Mental health harms are absolutely devastating because they're insidious, and they target seemingly preferentially younger people, unlike COVID. So, for instance, the CDC did a report in early June or late June rather, in the United States, and found that 1 in 4 young adults between 18 and 24 had seriously considered suicide in the month of June. Among all respondents, it was 1 in 10. Substantially higher rates of suicidality than we had previously seen in previous years. And again, as a consequence of lockdown, people are not meant to live alone, live locked away from the company of others. And the psychological harm from that is enormous, and the suicidality is sort of the tip of that. Okay, so what can we do with this fact? Well, the Great Barrington Declaration is something I've worked on to sort of use these facts that we've learned to change COVID policy so that we protect the vulnerable and reduce the harms that we impose on the people who are not vulnerable from COVID. So who are the vulnerable? Well, we've just seen older people absolutely are more vulnerable. There are other risk factors that might make you vulnerable. We've actually done a very poor job in some sense in protecting the vulnerable. For instance, we require workers who are essential, even if they're older, to go out into the workforce and expose themselves to COVID, even though they may be at high risk for mortality should they get COVID. It's a very unequal kind of system where we protect younger people who are richer from having to work and exposure to COVID, even though they face lower risk. I think nursing homes also famously were places where a large fraction of our COVID deaths, not just in the United States, but around the world, frankly, have happened tragically. So protecting the vulnerable means using the resources we have to better protect people in those kinds of settings, provide maybe workplace disability accommodations so that people who are older can have different ways of work that don't force them to be exposed to SARS-CoV-2. For people who are living in multi-generational homes, when there's a case in the home or a suspected case in the home, we should provide places in the community where people can isolate apart from their family for a while until the risk abates. I think we've spent trillions of dollars now in addressing COVID. If we spend even some fraction of that on protecting the vulnerable, I think the idea of focused protection on the people who are truly at high risk, we could do quite a bit better. As far as the rest, the harms from the lockdown are substantially worse than the harms from COVID. Right, so the 1 in 4 suicidality, the missed cancer treatments and prevention, the missed vaccinations, all of those harms are absolutely enormous. And when you compare that with the harms that someone, like take a child in school would face, well, the harms from the lockdown are just much, much worse. We're asking children essentially and young adults and others to bear the burden of disease control, when in fact the main they don't actually benefit as much, and they have to pay enormous costs. A smarter idea is to let them free, reduce the harms of the lockdown for them, open schools, open our businesses. Now people will still, will take precautions naturally as a result of the community risk of COVID, but requiring all those closures multiplies the lockdown harms. And how do you protect the vulnerable? It is certainly possible, and I think we've gotten better at that over time. I think the nursing home deaths have declined over time in the United States and elsewhere. Redoubling those efforts will be very, very important. But that's the basic idea of the Great Barrington Declaration. Whereas the current policy, I think, to some extent, has exposed the vulnerable while quarantining the relatively non-vulnerable. The Great Barrington Declaration calls for a return to standard public health principles. Shield the vulnerable, provide focused protection for them while letting everyone else free. You may think of this as an idea that only I have, or my co-signatories, Dr. Martin Kulldorff and Professor Sunetra Gupta at Oxford, and Dr. Martin Kulldorff at Harvard. But in fact, thousands and thousands of doctors, public health professionals have signed this Great Barrington Declaration because the idea, it actually is a more traditional public health approach than we've taken with these lockdowns. The Focused Protection Plan would result in fewer deaths from COVID, and at the same time, fewer deaths from the lockdowns. Public health needs to balance these. We can't simply think about COVID as the only public health outcome we care about. We need to care about all of public health. And the Focused Protection Plan, the Great Barrington Declaration, is a call that we return to these traditional tried and true public health practices. Even in the light of an extraordinary epidemic like this, it would result in better outcomes than we have seen. Thank you very much.